So the case we selected was calcified left main stenting. I selected this case because we are more often seeing patients with calcified lesions because of the increasing aging population in our part of the world as well, and more people have access to invasive facilities now. So we are seeing patients with calcified lesion, and because of the recent improvement in stenting technique and publication of quite significant data to support left main intervention, and the results are almost as equal to bypass. So more and more left main interventions being undertaken. So I just selected this case. I selected this case just to go through and what are the pitfalls or complications we can face by doing cases like this. So this was a 75-year-old gentleman who has background of diabetes, hypertension, hyperlipidemia. He had a previous coronary artery bypass grafting done in 2005 with Lima and 3 vein grafts. He developed angina and presented to another hospital where angiography was undertaken, when we showed Lima to AD was patent and vein graft to PT was patent, but the other vein grafts to AM and diagonal were occluded. His ejection fraction was 60%. ECG showed T-wave inversion in 1 and AVL and leads V 4 to 6. Creatinine and full blood count were normal. Sugar was well controlled, as well as the LDL. This was amazing. The operator made an ad hoc decision to proceed to angioplasty. These are very high-risk patients. People, though he had a protected left main, but it was heavily calcified, and we need to discuss with the patient because there are ethical and moral implications before proceeding to do angioplasty, ad hoc angioplasty in patient lesions like this. So we attempted to do PCI to left main and circumflex with a 1.5, 2.5, 3.5 balloons, and attempted to stent with Zion's expedition stent, but failed, and the procedure was abandoned, and he was advised to continue with medication. His angina got worse. He consulted a few cardiologists, and they advised him to do something. They advised him rotablation for the left main. He came to me because I had done angioplasty on a few of his relatives. And this is the angiogram. If you look at this angiogram, you can see how heavily calcified this left main is. You don't need any AVIS or OCT to diagnose this heavily calcification. Though it's the protected left main, but there's a risk if a patient like this develop complication, you can't just proceed to emergency CABG, because redo CABG is not an emergency procedure. And if you undertake pericardiocentesis, there will be risk of damaging the grafts by the needle or putting a sheath or the pigtail catheter. So we have to be very carefully select your strategy doing these patients. So we just quickly go over what are the tools we have to modify calcium. Deposition of calcium between a promoter and inhibitor of calcium driven by vascular smooth muscles. There are two forms of coronary calcium can occur together. One is the antimal deposition, and the other is the medial. The antimal is associated with atherosclerosis and predict future events. The medial is deposited along the external elastic lamina and is associated with chronic kidney disease, diabetes, and advanced age. Why calcium is important? Prevalence is increasing, 18 to 24% and increasing, is associated with advanced age, diabetes, hypertension, hyperlipidemia, smoking, and chronic kidney disease. It predicts poor outcome and challenges for PCI. Balloon cannot cross, stent underexpanded, dissection, perforation, device failure, instant restenosis, and thrombosis. And there's increased peri-procedure morbidity and mortality associated with calcified lesion. A MACE trial showed lower procedure success rate and high 1-year MACE. There's well-documented algorithms, both by AVIS and OCT, and the higher the score, the greater the need for calcium modification. So what we have got to modify these calcium lesions? Non-compliant and compliant balloon has been around for ages. Sometimes they're successful, but they're more associated with dissection and perforation. Ultra pressure high balloon and chocolate balloon, but they're not available here. Cutting balloons are more, or scoring balloons have more greater success than the non-compliant balloon, and they're less associated with section and perforation, but they're very bulky to handle, and overall tougher to deliver. So what have we left with is the rotational atherectomy, which has been around for ages. What is the mechanism of rotational atherectomy? It's caused the ablation of the calcium and deflects from the soft tissues. Small micro bubbles are produced, 80 microns, which are washed out by the microvasculature. We have to select the burrs according to 0.5 to 0.6 burr to artery ratios. 1.25 or 1.75 burrs are compatible with 6 French. We have to be careful to avoid complication. We need to have backup pacing in certain cases. We have the rotor run should be short, and we have to look for the deceleration of the burrs, and avoid tortuosity, and don't use it in these vein grafts in single conduit. I will just quickly go through this. Legend orbital atherectomy is the same principle, implies the rotablation, but you will use one catheter, 1.2 millimeter, and the speed is from 80 to 120 repetition per minute according to the vessel diameter. We use vapor wire, which is more supported than the rotor wire, but it's unfortunately not available here. The new concept, which is very interesting and is intravascular trypsy. It implies a balloon with a marker with 2 emitters, and we inflate the balloon as normal balloons with saline and contrast, and give energy through these 2 emitters, which produces sonic pressure wave with a 50 atmosphere pressure. And we have to select balloon 1-to-1 ratio to the artery. Unfortunately, it's very expensive. $4,000 to $5,000 is not available here. So the only option we are left with rotational atherectomy if you want to modify calcified lesions. I selected, there are quite a few algorithms. I selected this one. Is also very busy, and it employs OCTRFs, how to manage to deal with these calcified lesions. So I will go back to, can we go back to पिछले वाली slide? पिछली slide. किधर से इधर से. So when we planned this rotablation for this gentleman, unfortunately I can't put up the angio CDs. I had asked my cath lab to make a copy, but unfortunately they didn't do it. So we carefully look at the angiogram to make sure there's no dissection by the balloon, prior balloon inflation. Then we plan this procedure accordingly. These are high-risk procedures. We have adopted a policy. For low-risk procedure, we give ticagrelor for 1 month, and high-risk procedure, we give ticagrelor for 3 months. So we loaded the patient with ticagrelor. We selected the right femoral approach because we want to have a good guide support with 7th French guide, and there was an osteal calcification. So we want to make sure that we do properly rotablate the ostium with a good guide support. Then we chose the rota extra support wire. This is one of the indications for the rota extra support wire. We need to have a good support for the wire to rail track the rota burr, because we have to activate the rota burr in the guide catheter and then ablate the ostium and distally. We selected a rota burr of 1.5 millimeter, keeping in mind the diameter of the circumflex. Then we plan to post dilate and then put a stent which could be expanded up to 4.5 millimeter in the left main coronary artery. So I'll just show you the procedure quickly. Run kar isko. Oh yeah. You. Kiss her. So we put a rota wire here. This is the activated the burr inside the, and slowly with a packing motion, slowly in, quickly out. This is, by the way, is not the first. It's after 10 runs, we short runs 10 seconds, and there was a significant decrease in the rotor speed of more than 10,000. We gave 30 to 45 seconds between the runs to wash out of the macro bubbles. This is a polish run. This is we make sure that the lesion is properly, the calcium is properly dilated. This is the stent. This is the post-dilatation with the 4-row balloon, and this is the final result. This is the previous one. It's playing again. Just quickly go through it again. Because we have to activate the bur inside the guide catheter just to nail that ostium, because there was significant calcification at the ostium. This is I think this is the 10th or 12th run. The initial runs were we couldn't. The technique of rotor ablation is you don't need to push, you just the packing movement. If you push, the burr might get stuck. And we selected 1.5 millimeter, keeping in view the diameter of the circumflex. And if I had not broken the calcium in the left main, then we would have upgraded to 1.75 burr. Dilatation of the lesion. When non-NC balloon, there's a stent, there's another stent just to make sure we properly cover the ostium, not too back, not forward. So we take a few pictures. This is the part was done with 4-row balloon up to 24 atmospheres, almost 4.5 millimeter. Thank you.